And the physician component, if you believe that palliative care has a strong component of palliative medicine, it was remarkable to think that even the designated expert in these programs might never see a patient and might only be there to sign CTIs and office notes and to provide bills. And that was the scope of it. So there was a huge quality, there still is, a huge quality issue in hospices, somewhat related to resources and somewhat related to the way the benefit was set up. And now the new cops are really working to try to change that. One more thing about eligibility, and then we're going to gallop along here. Medicare has established fiscal intermediaries in the United States. The fiscal intermediaries are legally charged with ensuring that billing is done honestly and money flows through them. The fiscal intermediary, for example, in New York is National Government Services, whose offices are in Minnesota. And each fiscal intermediary establishes guidelines for how they're going to view hospice eligibility. The guidelines are called LCDs, local coverage determinations. The local coverage determinations vary from FI to FI. That's an important thing to recognize. All of you, I think, got, or at least the physicians here, got the small handout with the LCDs. You have to recognize two important things. One important thing is that the LCDs are not mandatory. Even if the FI says it's mandatory, the regulations don't say it's mandatory. You know, so the FI has interpreted the regulations in an effort to try to prevent fraud and abuse by creating these descriptions of patients that designate the patients as sick enough to warrant hospice services. That's what the LCDs are. The local coverage determinations are the characteristics of different diagnoses that mean the diagnoses are advanced enough to warrant hospice. What the regs say is that it's a physician judgment. And even the LCDs, if you read the LCDs for our FI, for example, it talks about comorbidities as needing to be considered in every case. And it provides two separate avenues for eligibility, one that uses the LCDs and one that uses evidence of progression of disease, apart from the LCDs. I can tell you from my own personal experience, testifying in front of administrative law judges to try to get billing approved after the FI has disapproved it. I've done about 300 testimonies, and I have won 95%. Because when an ALJ has to use these regulations, and here's why the medical judgment was that the patient is still eligible, 95% of the time, at least when I argue the cases, 95% of the time the ALJs agree. They disagree with the FI, with National Government Services, they agree with me. Because National Government Services has our records reviewed by nurses who may not be able to get from the record what the clinical judgment was. And they may be looking to see whether or not there's strict adherence to the LCDs, but strict adherence to the LCDs is not required. Okay? So that's just important. When you guys are out there, the physicians among you are out there, and you're being asked, is this person eligible for hospice? And you see a patient with CHF whose EF is 25% and not 20%, you don't say the patient's not eligible because the EF is 25%. Or when this patient loses another 5% of the EF, he's eligible for hospice. Right? That's absurd. Right? That's absurd. But that's what you'll see. Sometimes some organizations I've seen have checklists, and it says patient must have, and then it has EF of 20%. Well, that doesn't matter. The patient could be profoundly cachectic. 5 hospitalizations in the last 6 months for sepsis. Stage 4 non-healing decubiti. And if the EF is not 20%, they're ineligible. It's absurd, right? So it's a clinical judgment. Okay. Patients, once they elect, they can revoke at any time. They can revoke at any time. It is never appropriate in my judgment. I'm having discussions about this now, that's why I'm laughing. It's never appropriate in my judgment to make people revoke. So I call that forced revocation. So patients are told, for example, well, if you want that treatment, you'll have to revoke your benefit. So that's not legal. So we should never force a revocation. If a treatment is out of our scope, we can discharge. Why can patients be discharged? They can be discharged if they move out of the area. They can be discharged if something changes and they'll have a life expectancy of greater than 6 months. So if they no longer meet eligibility, they can be discharged for gross abuse. In other words, if they are violent, we're allowed to discharge them. It's often not known that the benefit was set up with caps. So there are two kinds of caps. One kind of cap we do deal with is in New York, and that is the amount of the number of hospice days across the agency that patients can be inpatients. Does anybody know what that is? This is a common myth, right? I mean, if you go out there on the floor and you say to patients, what's hospice? They think that hospice, they still do think hospice is a place in the community where the dying go, right? So that's not what it is. It's a home care program that allows access to institutions. The access to an inpatient stay for the agency overall is limited to 20% of the days. Hospice programs must take care of 80% of routine home care, and no more, at least 80% of routine home care, no more than 20% CIP. We'll talk about that in a second. The other cap is a cap on the total amount of money that an agency is allowed to get. Did everybody know that this existed? This blows my mind. So the federal government said back in 1980-something that they would not pay an agency more than an average of something like $6,500 per patient. It's gone up a lot now. It's like $19,000 or $21,000 per patient, something like that. So actually there are agencies with very, very long lengths of stay in which the payment by the government exceeds the cap. The cap being the amount, whatever that is, $19,000, whatever, times the number of patients on an annual basis. And there have been agencies in the country that have had to pay back millions of dollars to the government. I don't know why that cap was placed there. It's rarely invoked. For the not-for-profit hospices like ours never get even close to the cap. It's only the for-profit hospices that get close.
It could be after Operation Restore Trust?
No, it came under the benefit in the 80s. It was part of the original benefit. In 1982 included the cap. So that's just something to know about. I mean, if you happen to leave New York, for those of you who are leaving New York and you're going to work for one of the large for-profit hospices, more than half of the hospice patients in the United States now are managed by for-profit hospices. For-profit hospices have been under the gun in the United States because their margins of profit, some of them are very high, as high as 20%. Whereas the profit margin for large for-profits are running in the range of 2 to 8%. Not-for-profits are running in the range of 2 to 8%, and the small non-profits generally lose money. The small not-for-profits generally lose money. So the for-profits are under the gun, and that's why the federal government will probably be changing the reimbursement system soon in order to try to reduce payments. They will maintain high payments early in the course of the election of hospice and toward the end of life, and then reduce the per diem during the middle time in an effort to try to discourage very long length of stay patients at nursing homes. If you go to a hospice, a for-profit hospice out there in the Midwest somewhere with 1,000 patients, 70% of which are in nursing homes, you and your CEO might be discussing the cap. What are we going to do about the cap? In New York, you'll never discuss it. Okay, what are the requirements of the benefit? So if I elect hospice, what does the law say I get?